So good evening again to those who are already on, and also welcome to those who might just be joining now to this live Facebook event. It's a live event, so we'll be talking around the topic of weight loss surgery is what this is really about. So I'm glad to be a part of this event of Northern Beaches Mums, particularly on this International Women's Day. So a shout out to you all there, and also a shout out to two lovely ladies in the room here with me, Mary and Nicola, who have helped organise this, and also Nicole and Larice from Northern Beaches Mums. I really appreciate the opportunity to talk about this. As I mentioned, this is a live event, and I'm very keen to answer questions. So there's definitely an opportunity for you to post any questions, which I will see and I can address as I talk, as I go. But I will be talking around the subject of weight loss surgery, as I said. I'll also talk about who this is potentially indicated for, and that's probably why most of you have joined. I'm in the Northern Beaches Hospital at the moment, and they are helping host this event, thankfully. I do have rooms down the road, and I also consult further afield. This is a prime place for me to operate. We have excellent staff and facilities here, and I've been undertaking the weight loss surgery here since it opened about 5 years ago. So regarding weight loss surgery, maybe a good starting point is just to talk about who I am and how I got into this. I'm a trained general surgeon and upper gastrointestinal surgeon. So I go through all my medical training. I then go through specialised surgical training, which really focuses on the abdomen and the gastrointestinal tract. And as I trained in that field in the past, was exposed to the weight loss surgery and seeing how this helped people along the way. And it certainly has become a far more accepted procedure and access procedure for people who feel that it's appropriate for them. So I chose to have a subspecialty in this field with the bariatric surgery. That's another point to make, is that you may see the term bariatric surgery. That's another way of talking about weight loss surgery, or even metabolic surgery. You may have seen those words talked about. So I've been undertaking this surgery for more or less a decade as a consultant surgeon, and also doing training before that. It's one of the most common operations I do, and there's a variety of weight loss operations that can be offered, and these are done sort of on an individual basis when I see a patient who's come to explore this option. You've probably heard the terms sleeve gastrectomy, laparoscopic sleeve gastrectomy, gastric banding, gastric bypass. These are terms that often get confused even amongst doctors in the medical fraternity, so don't feel alone there. And we'll talk about those tonight, and also when people come and see me, obviously I'll give them some more detail about the operations and which one is best for an individual person. Again, not a bad starting point beyond that is talking about how patients initially come to see me, and then what actually happens to get to surgery, if that's decided upon, and what are the steps along the way and beyond. So when a patient comes to see me, they usually have reached out with a phone call to my lovely secretary Tracy, shout out to Tracy, or they'll make contact, or they might be seeing their GP. You may have seen your GP, and you may have known people that have seen their GP and have potentially explored this option. And then they come and see me with a GP referral. So a general practitioner will certainly advise you in a very open, honest way if this is something that potentially should be explored. And I do see GPs and give talks to them to educate them about who this could be indicated for. A person may have been struggling with their weight for many years, and the reality is most people that come and see me, this has been a chronic problem. So if you're considering if weight loss surgery is appropriate for you, then it's not just a binge over Christmas period, for example. It's usually been a long-term struggle. And you wouldn't be alone in that respect. We know that the overweight condition and obesity is extremely common now, and it's a burden for an individual, absolutely, and also our society as a whole. 2/3 of people either are overweight or are in the obese category, and 1/3 of Australians, and probably even more so now on updated statistics, are in the obese category. That term may not always be used, but that you'll still see the term obesity used in terms of the surgery, the weight loss surgery. It does follow a lot of guidelines that I operate by and ensure that I follow to ensure that it is only offered to people who it should be offered to, really. So as mentioned, it's usually when someone's been struggling for years, and the story is often that they may have struggled from their adolescence sometimes. People talk about school days. Another common time people mention, obviously women, is following a pregnancy, maybe their first or second pregnancy. And the trouble with being overweight is multifactorial. It's not a particular thing necessarily in an individual. It's our whole society. We're all exposed to the ready availability of high calorie dense food, the quick and easy foods. Our diet is calorie dense, generally speaking. Our lives are stressful. Some people have emotional eating habits, some people have cravings. We all have binge eating episodes. So it's multifactorial. Some people struggle with exercise because of musculoskeletal problems. And as mentioned, often after, say, pregnancy, there's changes. There's probably metabolic changes. And, people have usually tried to diet, exercise, and rightly so. And that's always the first starting point. But I guarantee you, everyone coming to see me has tried, and they've usually tried on a recurring basis. They've also often tried medication. We can talk a little bit about medication, and I'm sure some of you have seen it. A common one prior to these newer injectable ones has been Duramine. That's a tablet form, and these newer ones, the injectable ones that you would have probably seen in the media, often reserved for diabetics, depending on the type of medication, and these aim to suppress the appetite. So many people have tried these medications. Not everyone wants to try medications. They have to be injected on an ongoing basis, and there's cost and discomfort, and they can have, obviously, side effects in their own right. Also, another prerequisite for someone that is considering weight loss or bariatric surgery is the extent of their weight struggle. So, look, the common way that I and colleagues like me determine these things is based on the body mass index, which accounts for height and weight. And a healthy body mass index, BMI, is in the 20 to 25 range. Above 25 to 30 is the overweight range. Above 30 is where the classic term obesity has been used, and above 40 is where the term morbid obesity has been used. And you can even go onto my website, for example, and plug in your height and your weight in kilograms, and it can give that figure. Look, essentially, in an overweight category of a BMI of 25 to 30, it's not indicated. Above 30, it may be indicated. Obviously, at a higher end of the scale, people with a body mass index above 40, then it's increasingly indicated, obviously dependent on other factors. But a BMI above 30, if it's been standing for a while and people have tried to exercise, diet, tried to make changes to their lifestyle, and have health problems, are potentially eligible for surgery. And as mentioned, you would be seeing your GP, and they would be helping you to make these decisions, and you may be coming to see me. And that does not necessarily mean that you are having surgery. I'm very open and honest when I talk about the benefits, risks of surgery, expectations, what happens along the way. I'm sure a lot of you have done reading about the surgery, so we might just come on to the types of surgery and what it means. So, common one is the laparoscopic sleeve gastrectomy, and I've got a picture here. Hopefully we can see this reasonably well. But a starting point is the stomach. You'll probably be familiar with that picture, and basically that is the organ that where your dinner plate of food enters, and your stomach can stretch like a balloon. So it can hold a lot of food, and it sits there for a few hours to digest before moving through the bowel. The sleeve gastrectomy, there we are, turns that into a tube. So it can't stretch like a balloon. You fill up very, very early after you eat. And there's a lead-in diet to surgery of 2 weeks of usually a liquid, low-calorie diet to make the surgical conditions optimal. And then following after surgery, which is keyhole, and you're in for 1 to 2 nights, usually in hospital, and you're going home walking, sipping on fluids. I have you on fluids for a couple of weeks, a fluid diet that the nutritionist, the dietitian educates you about, while that's healing. Following 2 weeks, you then have a pureed baby food. A lot of you will have babies, so you may be sharing their meals. Again, that's to protect this stomach, this new tube or sleeve stomach, and then you're gradually getting on to pureed or soft food. I might make a comment that I'm not putting, and surgeons that do this operation are not putting a sleeve around the stomach. That is sometimes thought to be the case. It just is that the appearance of the stomach looks a bit like a narrow sleeve. Everything else stays the same with the surgery. So your food is swallowed down, enters this small sleeved stomach here, then comes into the bowel, of which you have about 5 to 6 meters where the nutrients get absorbed. But you're delivering a lot less calories by eating a far smaller meal. And I normally say to someone who's coming to see me for the first time, once you get through the phases of the recovery phase with your diet over 4 to 6 weeks, it might be you're having a quarter of a cup of solid food at one time when you're feeling pretty full. But that gets easier over the 12-month period, so it might be a cup of solid food at that 12-month period. Hunger is often reduced as well, particularly early on, because the hunger hormone is mostly secreted by the top part of the stomach, this top part of the stomach here, that comes out with the surgery. And that's usually a prominent feature as well. I see there's a few more people coming online, by the way, so welcome to the live event about weight loss surgery and who this may be indicated for. Welcome, and please ask any questions on the comment section. We've just talked about the sleeve gastrectomy, and I might just continue on with what a normal patient pathway would be like after the sleeve surgery before I move on to other types of surgery, just so you get a bit of an understanding. As I said, a patient will see me initially, often will come back to see me after having some initial blood tests, some screening tests, having a think about the options. We can talk about how potentially to undergo the surgery shortly as well, in terms of how you can fund the surgery, for example. When a decision is made to have surgery and I feel it's appropriate, then we involve my dietitian, nutritionist. And again, shout out to the female nutritionist I work with on this International Women's Day. They will help you understand what the surgery means in terms of how to change your diet afterwards. I give all my patients this very specialised, excellent book, specialised for people having the surgery, with a lot of appropriate recipes and things to have after the surgery, which are really nutritious and tasty foods, but it's been designed by dietitians that have worked with patients having this surgery for decades. The dietitian will also take you through the lead-in diet, 1 to 2 weeks leading into the surgery, where you might lose about 5 kilos, 10 kilos sometimes, which makes the surgical conditions better for me, and you often are actually feeling a bit better in that time frame. And it's important to note that you've got a goal at the end of that 1 to 2 weeks of the surgery. So you've probably tried a lot of diets on the way, and usually the problem is being able to maintain them. But obviously in this situation, we're trying to make the surgical conditions optimal for you. You have the surgery, and then you go through the transition phase. It's not a never-ending diet that often people yo-yo with and often end up increasing their weight. The surgery's keyhole often takes about an hour or so. It's when you're fully asleep under general anaesthetic, so you don't feel anything or know anything's going on. The anaesthetist puts you to sleep for the operation. There's 4 to 5 keyholes. With the sleeve surgery, that part of the stomach that comes out is permanently removed. That's an important thing to note. So it's important to understand that obviously before you're making a decision to have surgery. But in those patients that we agree it's indicated for, there's no real substantial consequence of it. You've still got the tube stomach left that secretes the stomach juices necessary. You're going home then on the fluids that you're sipping slowly. You're walking quite freely. The pain is not normally that much, and there's medicine in hospital, injectable medicine in hospital to make you very comfortable. There's medicine for nausea, which is maybe present for 24 hours. Everyone's a bit different, but almost always by the time you go home there's no nausea. And again, for 2 weeks you're sipping slowly on the fluids. You're doing this at home. You're coming back to see me at 2 weeks. The dietitian is also seeing you around that time as well. And then you're progressing on the diet phase beyond that. Exercise, look, it depends on the level of exercise, but it might be 2 weeks where you can walk very freely. You're probably getting back to work at this stage. And then you pop back and see me around the 3-month mark or in the interim if there's any issues. And you see me for a 2-year period because it's important to support you along the way, help you make the transition, monitor your progress, check your blood tests usually once a year to make sure nutrition is adequate. You're taking multivitamins which are recommended to just supplement your nutrition and ensure it's okay. I also am increasingly involving you with an exercise physiologist, and I work with, so in my room's just down the road from the Northern Beaches Hospital, I work with the metabolic team at Brella. It's a multidisciplinary clinic with excellent multidisciplinary service of dietitians, psychologists, exercise physiologists, who not only help with the surgical patients that I treat, but also if I deem that someone maybe is not appropriate for surgery at the moment, or alternatively they may not even have seen me and they've attended there up front, then they've got an excellent metabolic program, which I have a little brochure for here, just so you can see. So obviously not everyone's appropriate or choosing to have surgery, but even those ones I do treat, I involve them with an exercise program and also a counselling support program that helps you along the way, because a lot of it is about the mind in reality, and we all struggle in our various ways. And also, you know, people have developed habits over the years that maybe we're not always aware of, and it's helping to develop a bit more insight, because the surgery is best viewed as a tool to help you make important changes to make this a long-term sustainable outcome. As I said, you'll be seeing me for 2 years, and I'll be involving you with the dietitian. I might just talk about other forms of surgery as well at the moment. We talked about the sleeve. Gastric banding is a different operation, but often people think about them all the same. It's not done so much nowadays, but I did do one recently for a patient, and it's where a ring, this ring here, is put around the top part of the stomach with the keyhole surgery. So nothing is removed, no stomach is removed from you. It's not a permanent operation insofar as the band can be removed if need be. And the idea is food sits above that band, makes you feel full before it moves into the stomach. There have been problems with people getting an effective outcome from it, tolerating food well, regurgitating. But if people know how it works, really want to make the changes of chewing slowly and well, it does need adjustments with a little needle, so maybe once a month to get it to the right setting. And that's not done under anaesthetic, that's just done in my clinic. Then this can be an appropriate option for people. And look, I always mention it to people as an option, provided they know what it's about and they think they can make it work for them well. That's a gastric band, so nothing's permanent, no permanent removal, but the sleeve does have a permanent removal of a substantial part of your stomach. And the final one, there are a number of options, but to keep it simple, there's this gastric bypass operation where the stomach is stapled, wrong hand, sorry, there we are, to make a small stomach pouch, but the food is detoured or short-circuited through you. It misses about 1 metre, 1.5 metres of the bowel and this bulk of the stomach. So the food takes a short circuit and goes through a small part of the stomach. So again, your portions are small. The bypass of the bowel leads to effects of hormone changes, metabolic or hormone changes, making you feel less hungry, fuller. The medications that you may have heard of, these injectable ones, are aimed to mimic the effect of this operation, but they do so in a less profound way. So that operation has some extra ways in which it works and is appropriate for people that may have reflux, diabetes particularly, or who have a substantial amount of weight loss to lose. Now, I'd see a few questions coming through, so I might just move to questions just for the moment. First one I see is, how long is the hospital stay? The short answer there is, I plan for people to stay for 2 nights. You may have an operation on Wednesday, it means you're going home on the, Wednesday you're going home on the Friday. Some people, it may be 20%, something like that, may go home after 1 night. So if you're having surgery on Monday, you may go home on the Tuesday afternoon. The occasional person needs to stay 3 nights, but it's very much quite reliably within that time frame. Another question I see is, can someone who got their gallbladder removed undergo this surgery? And the short answer absolutely is yes. Gallbladder surgery is another one of these common operations I do. There can be a little bit of scar tissue sometimes, but that's usually easily dealt with. Sometimes people have had major operations on their abdomen with extensive scarring. I've got a couple of patients at the moment who I'm looking at operating for shortly. And it just takes a bit of extra time and care on my part to work through the adhesions or scar tissue to access the stomach for the surgery. So yes, absolutely, if you've had your gallbladder out, you can still undergo the surgery. Another thing that just came to mind was about how is it that someone eats after this surgery? You know, some people sometimes look at potentially having the surgery, but they're not really wanting to reduce, how much they eat or their eating lifestyle. The reality is that, especially with a sleeve, for example, your portions are going to be less, and that's the main way the operation works. I would say, though, that the eating quality is good once you go through the phases. People normally eat any type of food, and obviously I want you to eat healthy food, as talked about in the recipe book. It's extremely rare for someone to have regurgitation or vomiting problems. People usually feel very satisfied, And as I said, over the 12 months, the amount they can have is more. And I find it's a well-tolerated operation. Some people can get reflux, even a few years down the track, but the tolerance is far better, particularly compared to, say, a gastric band, where people can struggle for food to move through that ring. And it's usually a bit better than the gastric bypass as well, because it's a more natural, simple flow of food moving through. I think there's another question I just saw, which is how much weight could I hope to lose from sleeve surgery? So obviously it's dependent on someone's starting weight. Let me just talk about some numbers here. So let's say someone comes to see me and they're 150 kilograms, and surgery I deem is indicated and someone understands what it's about, and we undertake the sleeve surgery. Just say their ideal weight, which means a BMI, body mass index of 25, just say their ideal weight is 70. So between 150 and 70, it's about an 80 kilo loss. So coming down broadly, getting down 50, maybe 60 kilos from that 150 is realistic. Obviously everyone's different, there's a range. I find the sleeve quite reliable with what we can attain, and people can go from 150 all the way down to 70, no doubt about that, but I make sure that I don't create that situation because someone's vomiting. The expectation is someone eats in a healthy way, is happy with how they're eating, and they get their weight down. It's particularly those who make good changes with their lifestyle, food choices, exercise habits that can get back to a completely normal weight. So the starting, how much you lose is dependent on where you're starting from, but normally about 2/3, 3/4 of your excess weight. Another question I see is, what are the risks of weight loss surgery? Excellent question. So it depends on the type of surgery. The sleeve surgery, we can see there's some staples. These staples here keep the stomach sealed, so the sleeve surgery removes a substantial portion of the stomach. The gastric band does not have staples but this ring around it, and the bypass has this staple here but also joined to the bowel here. So the risks, look, anything substantial risk, be it infection, leakage on the staple line, bleeding, might need a blood transfusion or return to theatre, blood clot, these sort of more significant complications obviously, I'd say are in the order of 1 to 2%. So it is uncommon, and there can be other things that can happen along the way. So reflux is mentioned with the sleeve gastrectomy. It's very uncommon for it to be a serious problem, but obviously sometimes it can be an annoying problem, and sometimes people need medication for it, for example. And anaesthetic risks, anyone undergoing an anaesthetic has a risk, although they're remote risks, but you can be allergic to a medication, you can have a blood clot as a result of surgery, like going on a plane. Another thing to talk about is risks of nutrition over time. So the recommendation is to take multivitamins, eat a well-balanced diet. Often people are already a bit malnourished before surgery, is a reality. Sometimes the vitamin D may be low. It's not really often a big problem, people that are compliant with the multivitamins, for getting nutrition problems. It can be more common with the gastric bypass because 1.5 meters or so of bowel is not having food go through it. So iron deficiency can occur, which is already a common problem maybe amongst some of you. And down the track, the gastric bypass does have a small risk of an ulcer on the stomach or a bowel twist. That may risk maybe 5% at some stage in the future. That kind of risk doesn't really exist for the sleeve gastrectomy. And the gastric band, it's more about the tolerance usually of it, but sometimes the stomach can move on the band and it might need corrective surgery. I hope that's answered that, but obviously I'd go in more detail when I would see any of you or anyone you know. Another question, if you have a gallstone present which is being managed, will I need that to be removed? or can it be removed at the same time as a bariatric surgery? So it can be removed at the same time as a bariatric surgery, absolutely. I do that from time to time, particularly if it's symptomatic, if someone's having pain from it. There's an option of removing the gallbladder if we know there are stones there at the time of surgery to stop it becoming a problem later on, but it's not routine to just remove someone's gallbladder at the time. But yes, absolutely, I can do it at the same time as the bariatric surgery. And what happens if you have a hernia or one is found in surgery? So that hernia is probably what you're talking about is a hiatus hernia. A hiatus hernia is where your stomach has come up into your chest a little bit, usually a way you've been born, which can cause reflux. And look, I'm always looking directly at that when I'm doing this type of surgery. So if I identify it, I fix it at the time. So that deals with the hiatus hernia, and that's normally to address any potential problems with reflux. If someone has a hernia where they've got a bulge on or a swelling on the belly button or in the groin, I mean, obviously I would see someone and examine their abdomen, but that could potentially be managed at the time, yes. Now that's all the questions for the moment. What I was thinking we may do next is I might invite Mary in now. She'll come and join me here. Mary, thank you very much. I'll just introduce Mary and she'll say hi.
I'm rolling in. Sorry, my chair won't roll. There we go.
So, look, very thankful for Mary for coming in. She's had surgery herself, and she may be someone you may like to ask some questions about. But she also runs a very successful business that I use regularly for patients who are looking at potentially funding surgery with superannuation. And I can talk further about how you may go about funding surgery or how you can go about it, if in the public system or private. We can talk about those options. But commonly people are or using superannuation according to ATO, Australian Tax Office guidelines. And Mary can talk about that, because I refer my patients who are using that to Mary, and she helps them along the way. So I might let Mary just talk a little bit about her team and how they may be able to help you if you're interested.
Yeah, I'll just tell you, I had my surgery. I had a gastric sleeve. So this one here, I had the gastric sleeve about 4 years ago, prior to COVID. I had no complications whatsoever. I was in hospital 2 nights. I came home. I was a little bit sort of frail, but no pain, no nausea. They sent me home with all of these drugs, to which I used none. I did fantastic. I did the liquid diet that Phil talked about. I went to Woolies and I bought organic bone broth, and they gave me some protein water as well. So between the bone broth and the protein water, you just sip a little bit. You can't really tolerate too much food. You just sort of sip a little bit of bone broth. It would take me about half an hour to sip a cup of bone broth in those early stages. And then I think that's 2 or 3 weeks, and then I think the nutritionist said I could start on scrambled eggs. Well, I love scrambled eggs. So when you're in the soft food stage, I'd have a bit of scrambled eggs and try and stick to the protein, take my multivitamins. And someone else asked a question about how much weight could you expect to lose. I was 143 kilos and I got down to 90. So my goal weight would be probably 75. So 75% of the weight that I wanted to lose. Yeah.
Fantastic.
So I would thoroughly recommend it. I've had no complications and no problems at all, and it's been life-changing to me. I got to the point where I felt like I'd tried everything. I had spent thousands of dollars on well-meaning people who I genuinely thought they would help me, but I went and saw a biochemist and he told me, it's your liver, you need to go vegan. And so I went vegan for 6 months. I lost no weight. I went to a personal trainer and I was working out 5 days a week. I lost no weight. I gave up gluten, I gave up dairy, I gave up sugar. I don't drink alcohol. Like all of these things that, what's meant to fall off you, none of those things worked for me. And so when I found out about surgery, it was really a really great option for me, and I'm very grateful for it. Don't know if there's any questions about that, but I'm more than happy to answer any questions that you might have. about someone who's actually been through the surgery. Yeah,
Well, your team is the Super Health Ensemble.
that's correct.
And as I mentioned, I refer patients through to you, and they, get in touch with you, and they often ask you common questions.
Yep.
And maybe some of you are wondering, how long does the superannuation process take once someone's
Okay,
decided
that's
on
a
that?
great question. So, we need to do an application to the ATO. So it's some certain documentation we need to have for the ATO. It'll take you about a week to get all that documentation together, and then we submit everything to the ATO. The ATO will take at least 2 weeks to process your application in the current environment. When you work with an organisation like us, we have a great working relationship with the ATO, and we can call them and see if we can get you escalated and move forward a little bit faster. And then whilst we're waiting for the ATO to give approval, we do all of your superannuation documents. So we have a big database of all the super funds in Australia, and we know, if you're with AMP or HESTA or REST, all the documentation that those super funds will need. We'll get all of those ducks in a row. So as soon as the ATO says yes, but then we can lodge everything with the super fund and get the super part of your withdrawal moving, and we call the super funds every day and just check in. How is it going? How's it going? How's it going? Because we want you to be at the top of the pile, and your withdrawal to be escalated a little bit faster than everybody else's, so that you can have your funds ready to go and pay for your super. So all in all, 4 to 5 weeks. It would take 4 to 5 weeks for the process of having the funds released.
And if obviously it depends on what superannuation someone may have. I mean, sometimes people have used their spouse's super.
Yes, correct.
Scheme. Is that possible?
Absolutely, yeah. So you can use all of your super, all of the withdrawal from your super, or all of the withdrawal from your spouse's super, or you can take some from your super and some from your spouse's super. Go 50-50 if that's something that you want to do. Yeah.
Now, part of the process is me as the specialist, but also the GP needing to provide a letter of support, and
correct.
We need to follow the medical guidelines that the ATO
Absolutely.
have. But if I and your GP deem that appropriate, will it be approved in your experience?
People often say, will I be approved? Will I be approved? So what we do is we have a very thorough checklist, and we go through all of the checklist, and we make sure that the documentation that we're submitting is everything that the ATO require. We would rather go back and have a chat with Tracy and say, Tracy, you're Tracy. Tracy, could you amend this document a little bit? I think it's going to need to say this. Or we'll say to them, look, you need to go back to your GP and ask them to change this slightly. We'd rather we fix it up front so that your application goes through smoothly. We've done this so many times now. We know exactly what the ATO is looking for, and we make sure that we meet all of their requirements. We've never had anyone rejected. So we do all of the legwork up front to make sure that it goes through smoothly.
Yeah, and that's my experience with the patients I've treated, absolutely. So I highly recommend, Mary. Talking about what I was mentioning before about, someone coming to see me, they would have done some research already, but talking around costs and things like that. I mean, one thing to talk about is the easy thing is when a patient is privately insured and they're in the highest level of insurance, because normally the health insurers, be they Medibank Private or Bupa, need you to be in the highest category now to fund the surgery. So look, general costs for the surgery with the 2 years of support and, the allied health support and coming to see me and the surgery and all the surgery, all inclusive around, is in the order of 5.5 thereabouts. The next thing is when someone doesn't have that highest level of insurance, then what options are there? Well, this is where super comes in. Some patients have severe obesity with a lot of medical complications that may be able to be treated through the Medicare public system in entirety, but we can't do that at the Northern Beaches Hospital. Some public hospitals do that, but it's not a readily accessible thing like a gallstone in your public hospital, for example. And usually it's a long-winded process in the order of years, if that was even possible. So that's where people often come into the Northern Beaches, for example, without private insurance, but there's a cost obviously for the hospital and the nurses looking after you and the equipment in theatre and the special staples to make sure it's done properly. The total cost when someone's coming in as a self-insured patient staying for 1 to 2 nights, it's around the $17,000 to $18,000 mark usually,
Mm.
and that's where people often need, say, superannuation through Mary to help with that. So that hopefully gives you a bit of an idea about some costs and how it can go about it. Obviously coming to see me in the first place, we're making a decision if it's appropriate, indicated, giving you more information about it, talking about these options in a bit more detail. It's about getting your life back on track if you're struggling with your health.
Absolutely.
Potentially with significant comorbidities, be they diabetes or sleep apnea, risk factors for heart disease like cholesterol and fatty liver and the like. And sometimes people are struggling just on a daily basis with their well-being, sleeping, exercise, mobility, these sort of things. Look at what it's about, and I like to treat everyone on an individual basis and see if surgery is appropriate, or see if they can be best helped with a dietitian or exercise management or medical treatment, and they can even be tried in the short term or long term if they continue to be successful. Mary, another question is, so sometimes people having the weight loss surgery have a significant amount of excess skin.
Mm-hmm.
In my experience, most people don't have it to such an extent that it really bothers them, but some people choose to have the excess skin removed, and I personally don't do it. A plastic surgeon may do that, but is superannuation being able to use for that surgery later on?
Absolutely, yeah. You can come back again and access your super for your skin removal surgery. Okay.
And that would, if that's decided upon, that would usually be at least 12, maybe 24 months after sleeve surgery. Some other, I think, common questions that people may ask you, can they claim for lost wages?
I do get that question a lot. No, you can't. You can only claim for medical expenses.
Yep.
So you need to have your quotes from your medical providers to be able to claim those things. But you mentioned your health group that you send people to, the metabolic health group. You could claim for that. All your vitamins that you need to take, you can claim for those. All of your protein shakes that you need to take, you can claim for all of those things. If you need to travel for your procedure, if you live in a regional area and you need to come into Sydney to have the procedure, you can claim travel for yourself and for a spouse, and accommodation for it's usually about 8 nights accommodation as well.
Yeah. Okay. Well, that's really comprehensive, Mary. As I said, I really recommend Mary, and she's got a website and she'll explain things very well. So some people need the superannuation and it's appropriate for them, and I've sort of got to make that decision on an individual basis. So look, I've been talking a lot. It'd be nice to hear some of you talk in person, which is not possible on a live Facebook session like this. Please send through any more questions if you have any at this moment. The session has been about is weight loss surgery appropriate for me? And hopefully I've addressed that a little bit, making you familiar what the surgery is about. You've probably done some research and not really sure, and it's about how long you've been struggling with your weight, how much it's affecting your health and well-being, how much you've tried, and you accept that it's something that you can't manage effectively just altering your diet. I personally think that a lot of it has been issues in the past, maybe with someone's habits, and they've put on a lot of that weight in the past, and often people may be eating reasonably at any given moment in time, but it's quite hard to get that past excess weight off, and surgery no doubt is the most effective way of getting a substantial amount of weight off. It's been scientifically shown in the long term to be superior to the conservative measures, although obviously conservative measures like dieting and exercise would be the simplest, healthiest way if it was effective. And then on an individual basis, we decide if it's appropriate for you on a risk-benefit analysis. And I've talked about the benefits and some of the risks, and obviously very happy to talk more about this with you if you speak with your GP and you choose to pop on down and see me. I think there's a couple more questions before we come to a close. What is Mary's website? It's the Super Health Ensemble.
SheAustralia.org.
So on International Women's Day, how's this? The website's SheAustralia,
.org.
.org. She Australia is Mary's website. One last question I see is, how long will I need off work? So it depends on your work. Very broadly, it would be 2 weeks. You know, it might be, if you're working in an office job, probably 2 weeks is reasonable. If you're working from home, even 1 week would be okay, to be honest. If you're running your own business from home, even short of that would be okay. The main thing is, like I've got a bit of water here now, is just being mindful through the day of sipping and keeping the fluids up. That's probably the most important thing. If you're in a physical job, obviously you might need a bit more time off. If you're a manual labourer, you know, it's probably more like a 4-week period, something like that. What is the wait time? Yes, I did see that question earlier and I missed that one. So the wait time for the type of surgery, well, for example, if someone came to see me next week for a consultation and, you know, came again and saw me a couple of weeks later and we decided that surgery was appropriate, then I could normally get someone in within a month or so of that decision for surgery. And there's a lead-in time of the preoperative diet, as I mentioned, but it's not a long wait time of months on end. You know, normally I can get you in on a short-term basis, and I try and fit you in on a basis of factors of family and work and other things that you may have going on. I might draw this to a close. I think there may be a link to my website. I think Nicole or Larice from Northern Beaches Mum might be putting this video online, so I think you can always come back to it. But I will leave that to her to talk about the practicalities of that. You may like to share it with people you know. And look, it's been a pleasure and a privilege on, again, International Women's Day. And thanks for Mary and Nicola and for having me here in the Northern Beaches Hospital, and hope to see you again. Bye-bye.